Thank you very much. And I'm very conscious of the most scary time pressure I've ever spoken under. So I may have to be stopped in mid-sentence. So I'm going to talk quite quickly. You do have copies of the slides, I think, in front of you. So if I'm going too fast, I apologize, but I hope you'll understand. Now, I was asked to talk about what patients want, and that indeed is what I'm going to do in part, but I'm also going to stray a bit beyond my brief to talk a bit about the evidence about what happens when you give them what they want in terms of the types of conversations they have with clinicians. I think what patients want has been best explained, best described by National Voices. National Voices is a coalition of health and care charities. They have about 150 member organizations. And they were asked by the Department of Health, I believe, or NHS England or somebody, to put together, following discussion with all their members and their members, a description, a narrative on what is meant by patient-centered care, particularly, or person-centered care, particularly focusing on people with long-term conditions. And I think it can be summarized. It's well worth looking on their website for the whole thing, because they've done, there's an awful lot to this, and they've also taken it further and developed principles for care and support planning. But in a nutshell, this statement in the middle summarizes what patients want. I can plan my care with people who work together to understand me and my carers, to allow me control, and bring together services to achieve the outcomes important to me. Now, Steve's already mentioned the weird assumption, actually, that professionals often make, that professionals manage long-term conditions. Complete nonsense. Actually, people with long-term conditions manage their long-term conditions with tremendous support, often from their family. Professionals see these people for a tiny proportion of their time. I worked out it's about 0.03% of their time. So people already self-care willy-nilly. They may not always be very effective at it, but that's what they do. Why is this not moving? What am I doing wrong? This is not going to help with the time pressure. Oh, right, sorry. Now, yes, they self-care, but my goodness, we make it very difficult for them because they live in a most incredibly complex world of services. This was an initiative by one of the National Voices members, Diabetes UK, mapping out all the people, all the different services and professionals that somebody with diabetes comes across. And look at the Alzheimer's one, even more complex. So people live in this very complex world of services. And the message they take away from that is really, we are all the experts. The professionals are the experts. You just bump around between the services. We'll refer you from one to the other. But really, you're not at the center of this system at all. You're buffeted by it. And we also managed to convey the idea that the decision makers in healthcare are the professionals and not the patients. This is despite decades long, and I personally have been involved for about 3 decades in looking at shared decision making, how you can actually get patients to make decisions for themselves about their care, or at least in conjunction with clinicians, how you can inform them and enable them. And this is a slightly depressing side, although, on an optimistic day, you can see a slight upturn. This comes from the National Patient Surveys, the NHS Patient Surveys, and, it is getting slightly better, but what it says is that about 50% do not have as much say as they would have liked in decisions about their care and treatment. Now, I mentioned that National Voices have developed these principles for care and support planning. They call it care and support planning. I tend to talk about personalised care planning, but I want to concentrate on that now. and the place of health coaching in this world. A definition, you probably can't read that, but personalized care planning aims to ensure that individuals' values and concerns shape the way in which they're supported to live with and manage their long-term conditions. And some of you will be hearing this afternoon, I think, from Sue Roberts, who's leading a workshop on the House of Care. The House of Care is an important model that was developed originally for working with people with diabetes and then later extended. And what Sue and her colleagues have done so successfully and succinctly is explained by using this metaphor of a house, how if you really focus on, if you really put patients at the center, really focus on getting personalized care planning right, then that has ramifications for the whole system. But I won't talk about that because Sue's going to be talking about it later. What I want to concentrate on is the middle of the house, which is personalized care planning. And to understand this concept, you need to first of all put yourself in the patient's shoes and think about what they really need to know to play their important part in managing their care most effectively. They need a lot of information. They need to know about the various options for dealing with their condition, the benefits and harms of these various options and treatments, the likelihood of the benefits and harms that may occur. But they also, very importantly, want to think through their own goals in managing their condition, or increasingly conditions, because of course many people have more than one. And they're certainly interested in what the health professionals' goals are, but the patient's goals are also equally important. They want to, and almost everybody does, it may not always appear that in the rather paternalistic system which puts people into a rather passive role, but in fact, when you ask them, most people want to do everything they can to help themselves, but they need support to do that. Now, we are used to thinking about professional expertise. Professional expertise is absolutely key, and all of you who are health professionals have studied for years and years to gain this expertise, and you've learned more and more as you experience clinical practice, and you know about diagnosis and the causes of disease and the prognosis and et cetera, et cetera. But the patients are also experts. And the patients, and only the patients, know what it's like to experience the illness in their particular social circumstances. They, and only they, know about their attitudes to risk, their values, preferences, and goals. So in order to share decisions, to co-produce health, you need to recognize and respect both sources of expertise and bring them together. So this is where what you've been doing so encouragingly, I think, in East of England, is really focusing on that conversation and changing it, because this is not the way much healthcare is practiced in this country at the moment. Now, shared decision-making, this new type of conversation, is appropriate in almost every situation. There are some situations where it isn't. There are emergency situations where what is needed is a professional with their particular expertise to make quick decisions on somebody's behalf. But that's actually only a tiny fraction of what happens in everyday NHS. But this kind of approach is relevant if you're making decisions about, sort of one-off decisions about should I have an operation or should I take this drug, if you're trying to manage chronic conditions, and indeed also for wellness and health promotion. These new type of conversations are relevant in all these contexts. And this just illustrates what it looks like. On the one hand, you have the patient's agenda, recognizing and respecting that, understanding it may be different from the professional's agenda, but the professional's agenda is also crucial for managing disease. So you've got to share information. You've got to then move into a process of discussion about goal setting and then planning actions and then following through. That's what you've been learning, I think, in all of you who've been studying health coaching. And of course, this isn't just a one-off conversation that happens once. This is a process that is continuous. And we've, in the research I'm about to tell you about, we conceptualized it in this way as a 7-step process, starting with preparation. People need to be prepared for this kind of different conversation. And various, again, you'll probably learn more from Sue if you go to her workshop about how they tackled the preparation part of it. Goal setting, very fundamental to health coaching. Accepting that the goals may differ, that it could be quite a complicated conversation about agreeing on goals. Then planning actions, what is needed to help you achieve your goals, the patient's goals. Then documenting, recording this, so that thinking back to those webs of care, all those people who the patient receives services from are also in the loop of what's been agreed. Then coordinating, making sure, and you know, the patients who have a care coordinator, somebody who leads for them, are very fortunate, because that helps them through the web of care. Then supporting, providing the support that's needed to help people change behavior if behavior changes what's agreed. And then reviewing, how are you doing? What else can we do to help you do better? Have your goals changed? And so on. And then round the cycle again. Now, I've recently finished, nearly finished, a systematic review of the evidence in this area, which I want to share with you. This is the first time it's been shared in public. Before I do, I want to talk to you about one particular study, which is in our review, which is a very interesting example from the US. It's called Team Care. And in Team Care, what they wanted to do was to tackle these issues of patients who had either diabetes that was poorly controlled or coronary heart disease that was not completely under control and had major depression. A very common scenario. Depression is a common side effect of these conditions. And they wanted to develop a means of managing or helping these patients to manage better. So they devised a series of tools focused initially on goal setting and action planning. That was the center of it. They also made sure that everybody knew about the latest and evidence-based guidelines on the drug treatments that were available. But the heart of this was health coaching. And the health coaching was quite intensive. So these patients met with either a doctor or a nurse every 2 to 3 weeks. And then they had nurse follow-up on a regular basis, using all the kind of coaching techniques, including motivational interviewing, problem solving, and developing maintenance or action plans. And the whole project was very carefully supervised and supported. So what the staff did was supported by coordinators. They had regular checkups, regular meetings to make sure that everybody remained on track. And this was a randomized trial. And it led to some pretty impressive improvements. They found improvements in HbA1c, blood glucose levels, improvements in cholesterol, improvements in blood pressure, improvements in depression, improvements in patients' quality of life, in their confidence to self-manage, and indeed, this was highly cost-effective, despite the intensity of the intervention. So that's one American example. One study doesn't make a summer, but it's a very good, I think, example of what we should be trying to achieve. Now, we wanted to look, we realized that there isn't at the moment a Cochrane review on this type of approach to personalized care planning, so we decided to do one. This was quite a challenging review. We were looking at complex interventions. We screened 10,000 abstracts. If anybody's ever done this, it's a nightmare, but anyway, you have to go through all this. We found 43 papers. Our criteria were pretty strict. We wanted to find trials, only randomized trials, where the aim was to actively engage patients in goal setting, action planning, and follow-up. So studies that didn't have that, or didn't have what we were convinced was an opportunity for patients to really influence what happened. In other words, the ones that just presented what I call the Blue Peter ones, a plan that somebody devised elsewhere and gave to the patient, those were out of our review. So we found in all 19 randomized trials which fitted our criteria. The majority, this always happens, come from the US. There was one each from Australia, China, Denmark, Netherlands, Taiwan, and only one, I'm afraid, from the UK. In total, these trials covered more than 10,000 participants. A majority, interestingly, were diabetes, 12 of the trials, but there were also patients with mental health problems, heart failure, end-stage renal disease, asthma, and one trial that had a variety of conditions. Most were primary care based, but there were 3 set in hospital clinics. All of the interventions, and they used a variety of interventions to get there, so they all were trying to achieve behavior change among the patients, but only 4 were also tackling behavior change among clinicians too. They all involved, as I said, goal setting, action planning, and follow-up and discussions with a clinician. They used a variety of tools, information packages. Many of them involved coaching of one type or another. Some were peer coaches. There were a couple of trials with peer coaches. Some used group visits as well. And the clinicians involved, again, right across the spectrum. A lot of them involved nurses and or therapists, but 6 of them involved doctors, 2 peer coaches, and 2 mental health providers, including from social care. When thinking about the outcomes to look for, our 4 primary outcomes were effect on physical health, effect on psychological health, effect on subjective health status, and effect on self-management capabilities. We also looked for evidence on health-related behaviors, on resource use, and on adverse effects. And here is what we found. So positive evidence, particularly, because remember all those diabetes studies, on blood glucose control. So HbA1c levels improved. Improvements in psychological health, particularly reduction in rates of depression. The evidence on subjective health status was mixed, partly because the studies all used different outcome measures, and it was very hard to pull them together. Self-management capabilities, self-efficacy was the most commonly measured, and again, that improved. Resource use, very few trials had looked at it, and the evidence was mixed. The Team Care one, as I told you, one of the best trials, showed very positive effects. And we found no evidence of adverse effects. So in summary, this is a very positive story that this review has to tell, and I hope will give even greater strength to your efforts to roll out health coaching. We learned a few other things from the review. I'm going to stop in 1 minute. Firstly, that those interventions that were more comprehensive, went all round that 7-stage cycle, were more likely to be effective. Those that were higher intensity, more likely to be effective. Those that were integrated with usual care, more likely to be effective, rather than those that were completely separate. And those where the clinicians were well supported, and that means thinking about behavior change among clinicians as well as patients. That's equally, if not more important. Those were more likely to be effective. Now, I have 1 minute, have I? No? 2, okay. I think I'm nearly there. So this I hope, not only gives more grist to your elbows, but also I think is further evidence about what we know, that the traditional way of organizing conversations or consultation skills is not effective. It creates dependency. It discourages self-care. It ignores people's preferences. That's why we have to change. We know that if you can use this approach, if you can inform and empower patients, then you're much more likely to get good outcomes. So what's to argue against that? I'm very excited about what you're doing here in East of England, and I do hope you continue, because it takes a long time to achieve this kind of change. Thank you very much.